To cure an internal pathology, a surgeon must first inflict intentional systemic somatic trauma. To understand the evolution of AAS, we have to examine its physiological rationale, the severe sensory and motor trade-offs it imposes on the physician, and how digital augmentation is currently extending the reach of human hands. Modern surgical principles prioritize the preservation of the patient's baseline physiology, treating the reduction of access trauma as a primary therapeutic goal. Every abdominal procedure requires an operative workspace. You need clear physical volume to move instruments and visualize the pathology safely. In open surgery, that space is created using mechanical body wall retractors. These devices use rigid metal blades to pull tissue apart by force. This mechanical retraction exerts intense, localized pressure, often leading to tissue ischemia and microtrauma at the points where the metal meets the muscle. Minimal access surgery offers an alternative to this physical force, the pneumoperitoneum. By inflating the abdomen with carbon dioxide, the system applies a low-pressure force uniformly across the entire body wall. This creates a stable workspace while eliminating localized pressure necrosis. Thoracic surgery requires a different mechanical logic. Because the ribs are rigid, space is created not with gas, but by using double-lumen endotracheal tubes to isolate and deflate a single lung on the side of the operation. While replacing mechanical force with diffuse gas pressure protects the patient, it introduces a severe sensory barrier for the surgeon. When a surgeon operates through small trocars using long, rigid instruments, they encounter a significant sensory motor gap. First, there is a visual penalty. The surgeon must navigate three-dimensional anatomy while viewing a flat, two-dimensional monitor, which removes natural depth perception. Then there is the motor penalty of the fulcrum effect. Because the port acts as a pivot, the instrument tip inside the body moves in the opposite direction of the surgeon's hand outside. Furthermore, the surgeon loses direct haptic feedback. They can no longer feel the subtle density of tissues or the hidden pulses of arteries with their fingertips. This sensory loss makes routine hemostasis, the control of bleeding, a technically demanding task. Because blood absorbs light, minor bleeding rapidly degrades the camera image. In a confined space, a small volume completely obscures the operative field. In an open procedure, a surgeon can stop most bleeding with direct digital pressure. In MAS, the hands cannot reach the vessel. To compensate, surgeons use specific mechanical adjuncts. These include rolled swabs, specially designed to be inserted through a narrow port. Manipulated with robotic or laparoscopic graspers, these swabs provide a larger surface area for gentle retraction and localized pressure to control bleeding. Standard minimal access surgery protects the patient from external trauma, but the resulting cognitive load and spatial distortion demand a level of coordination only attained through specialized simulation and mentoring. Robotic telemanipulation was developed as a master-slave interface to bridge the sensory and motor gaps created by standard laparoscopy. The system is built on physical separation. The surgeon sits at a remote console, removed from the sterile field, controlling the robotic arms through a digital hub. This hub restores high-definition stereoscopic vision, providing the surgeon with the depth perception that standard monitors lack. At the patient side, the robotic cart uses multi-jointed instruments that eliminate the rigid fulcrum effect. These instruments provide 7 degrees of freedom, replicating the human wrist. The interface provides tremor suppression, filtering out the natural micro-shaking of the surgeon's hands. Furthermore, software enables motion scaling, translating a large movement at the console into a micro-precise movement at the surgical site. The surgical robot acts as a digital intermediary, using computation to translate the surgeon's intent into stable, precise movements that exceed baseline human dexterity. With the mechanical barriers addressed, the digital interface allows for the next evolution, augmenting human vision with real-time physiological data. Because the surgeon already views the anatomy through a monitor, data overlays can be integrated directly into the operative field. A primary example is the use of near-infrared light and indocyanine green, or ICG, to visualize vascular and lymphatic structures. When ICG is administered, the camera detects differential tissue densities and blood supply that appear identical under standard white light. This allows surgeons to identify hidden lymphatic flow or define precise tumor margins with high confidence in real time. In open surgery, identifying these margins often requires physical palpation. Augmented reality replaces that tactile search with a live map of the patient's physiology. These tools enhance MAS by providing visual evidence of structures that are anatomically hidden or impossible to feel through standard instruments. The final frontier of surgical augmentation involves synthesizing preoperative imaging, like CT scans, into a live, three-dimensional intraoperative roadmap. Navigational bronchoscopy provides a prime example, using software to guide instruments through the complex pathways of the lungs. The software synchronizes a virtual 3D map of the bronchial tree with the live camera feed from the endoscope. This provides a guided pathway to lung nodules that are too deep or too small to be localized through traditional exploration. By accurately placing markers for resection using this digital guidance, surgeons can avoid the trauma of extensive exploratory dissection. Surgery has evolved from the massive somatic trauma of open access to a world of restricted but safer endoscopic visualization, and finally to robotic telemanipulation. MAS has become a computer-mediated discipline where hyper-precise, data-augmented visualization serves as a primary adjunct to, and often a replacement for, the gross physical exposure required in traditional surgery.